Now we will go for keynote lectures. I request Dr. Madan Kapre sir to be on the dais, please. I request chairpersons, Dr. Vimal Kasbekar madam, Dr. Rajendra Bohra sir, Dr. Avinash Deshmukh sir, and Dr. Prakash Dhond sir to be on the dais. The topic of lecture is Intraoperative Neuromonitoring in Thyroid Surgery.
Well, good morning, everybody. Do I start? Yeah? Okay. Good morning, everybody. I'm going to talk about the thyroid, which is close to my heart. But before I start talking, there are certain pleasantries I must do, for I shall never pass this way again. And that is, I want to thank all the staff of Ashwin Hospital yesterday, all the sharp vision people, all the operating room staff, and in particular, I know Prasad is young, but I never realized how young he is, because I've seen him working so hard and so energetically. It's almost infectious. So thank you, everybody, all the team of Solapur, and again, all my further keynote speakers, starting from Ashish Bhumkar downwards, for allowing me to sort of butt into this session, as I have to leave and get somewhere by 2 o'clock. Thank you very much, all of you, and thank you, chairpersons, as well. I'm going to talk about a disease which is extremely forgiving, but if you get into complications, those complications are unforgiving. You may not treat a cancer of the thyroid gland, the patient may go to his grave, and maybe in a post-mortem there will be that there was small focus of papillary carcinoma in the thyroid, which he had never known about. But you do the surgery and you give him a recurrent nerve palsy either one side, he spends his left voice like this. Or you give both vocal cord palsies, he's even worse because he ends up with a tracheostomy, or you knock off his parathyroids and he goes into tetany rest of his life. So therefore it's very, very important that we get it all right. Now recurrent laryngeal nerve palsy, it never happens to me. It happens to others. I am too good. It's not true. Even the percentage of 1 to 2% is also not true, because we don't put your hand on your heart and say, not the voice, but I actually do the indirect laryngoscopy to confirm that there is no palsy the next day. How many of us do it? I think if you look at the percentage, and it's a large study over 25,000 patients, the bumped up rate was 9.8%. So 9.8% means 1 out of 10 of your patient will land up with some degree of recurrent nerve injury. And that's not a small percentage. See this picture and you see so many horses. Can you count the horses on this picture? There are several horses. And therefore, visual examination is always bound to fail. And the failure is as high as 11% plus. I was speaking to my close friend from London, is a professor of thyroid surgery, and the rate of palsy is inversely proportional to the training and directly proportional to the ego. More the ego, more the palsy. So you should take that into account. Visually identified, surgically preserved, and so-called structurally intact nerve is no guarantee that that nerve is functioning. And we need technology to know that that nerve is functioning. I'll just briefly talk about the IONM setup, because there is a speaker who might cover this later on into his talks. It has got a stimulator probe, which is with the surgeon. It has got a recording device, which can record all the things that happen, plus there's an endotracheal tube, which is pre-fashioned and put across the vocal cords, and there are other technical backup support for you, and there's an interface connector box, which will take your stimulus to the monitor. Something like this. It looks very complicated, but believe me, it is not complicated. Once you get tuned into doing it, the setup doesn't take more than literally few minutes. But your anesthetist and your boy, there is a thing about having a neurophysiologist on board. That's what the company says, or that's what everybody talks about. It's not necessary. Any smart kid, I mean, how many of you have a smart boy in your OT who not even have got a degree qualification? I think most of us have. And those guys are much, much smarter and techno-savvy than us. So such a guy can be trained, and he could be doing your so-called neurophysiologist presence in the OR. This is the endotracheal tube. Again, a little bit of this tube. This has changed a lot of times. When I first started using it, it had just 2 electrodes, and they slipped right, left, and they gave you a guiding line. That if guiding line was in the center, the probes were lateral. It's no more like that. The tubes are wonderful. They are flexometallic, and they're very, very easy to use. That's the monitor. Now, this monitor, there is a thing called place it in front of you. Now, I don't believe in it. I believe on my ears, because there are different kinds of signal sound that come out of this machine if you hit a nerve or if you hit a vessel. The vessel makes a tambora sound, ting, whereas the nerve makes a doop. And the sound is so loud that when my daughter is operating in the OR and I'm having a coffee in the coffee lounge, I can still hear it there. And as soon as I said doop, I said, fine, I'm going now. Everything is okay. Now, what are the proven benefits? It reduces the risk of nerve injury. Now, when I say that, it is usually, I'm talking about complex scenario. I'm not talking about a straightforward surgery like we did yesterday. It has got a high sensitivity and a terrific specificity. And it also decreases the transient vocal cord palsy. What is transient vocal cord palsy? The transient vocal palsy are those who have got neuropraxia, and they will recover in a given length of time. You can even predict that also when you are using it. And of course, there are questions of litigation. In our country, it's no more a scene. My बाप सरकार, तुम्हीच माझे देव. आता तोच तुमचा बाप आहे. हे असं आता ऐकायला येत नाही. आता they go on the net. Dr. Google up there is a smart kid and not in your favor. He says and tells things to the patient which are probably not so comfortable for you. I'll skip this slide but come straight for the incremental values. You see, there are variations of recurrent laryngeal nerve. And the nerve can bifurcate, trifurcate. And now amongst all these 3 or 2 or branches, you want to know which of these 3 are the one which matters to me. And it's usually said to be in the books, it is the anterior branch. But believe me, it's not so simple. Because sometimes the anterior branch looks very, very flimsy, where the rest of the branch, the pharyngeal and the sensory, are much, much robust. And therefore, that is where it will come handy. And you will sometimes feel that, oh, I'm stimulating the nerve, but I'm not getting the signal. And maybe the thing is that you probably are knocked off the anterior branch. So all this kind of little information that comes to you handy if you have this equipment on board. Incremental value of non-recurrent inferior laryngeal nerve. Now there are 2 ways of knowing it. One is by radiology. I mean, we are all friends with radiologists. I mean, I keep on saying, yeah, you should marry an anesthetist, you should marry a pathologist, but nowadays you should marry a radiologist because they come to your help far more than your wife does. Anyway, coming back in a lighter vein, the RLN can be detected almost with certainty if your radiologist friend tells you that he has got an aberrant subclavian. If there is an aberrant subclavian, which means lysoria, we all know that, arteria lysoria, then almost certainly the recurrent nerve is not recurring. That's standard knowledge. But what is even more standard knowledge, where the nerve monitor comes in, is there are other variations of non-recurrent, recurrent. And those other variations that it loops around and it almost climbs up. And climbs up for the rest of the course in the neck, although it is not a recurrent nerve, with the inferior thyroid artery. It climbs up again. And this is a dangerous variation, because this is neither here nor there. And in such situation, it can be diagnosed and prevented from being injured if you got this equipment on board with you. If it's a left side, it is no-brainer. The patient has got a dextrocardia and you have got a bingo. I mean, anybody can detect dextrocardia in a pre-anesthetic checkup. Rare variations I just talked about. This is one which is very simple. It is going bang straight across you, but the other one is not easy. What are the other benefits? Does it help the trainees? And this is a catch here. This is not a monitor to detect the nerve. This is a monitor to detect the functionality of the nerve. When the young guys came in, they come with a prejudice. अरे मिल जाएगा ना उधर डुब डुब करके देख लेंगे. ऐसा नहीं होता. It's not like that. It is not a substitute for your dexterity or your surgical anatomy. But it increases the speed of detection. I am talking to the opposite things. You don't suspect idhar kidhar to bhi hai. So that idhar kidhar to bhi hai can be confirmed further by your dissection, but that much dissection direction you can get with this nerve monitor. But where does it make the real difference? And this scenario, I want you to spend a little time, maybe another half a minute. There is going to be a time in our country when we will stage our surgery. In America, it is a standard practice. In Europe, it is coming. In Seoul, Korea, they are on our lines. But in our country, it won't be long before we are starting to stage. When do you stage thyroid surgery? I've done one side completely nicely, but I'm not getting signal. That means I am worrying if this is a patient where I have knocked off the recurrent. I can always say, maybe apraxia, I've seen the nerve, but would you venture to go out on the opposite side? Or would you then say, okay, let's stop today, I come back the other day and tackle the other side maybe 2 weeks later. This is bound to come in our country, particularly if you are operating on a scenario where we are dealing with malignancies. This is not a crowd I know where these are all probably not going to do cancer thyroid surgery every day, but something we should think that in places where we do staging, this is very handy. And it's not about just the nerve. You see, when you do, how many of you had this very embarrassing experience that you do a good thyroid surgery, you done very nicely, very happy, clap, clap, clap everywhere, but post-operatively, the imaging guy, the endocrine guy or the radionuclide guy, puts a slap on your face, say, oh, so much tissue left behind. There is a thyroid tissue on the bed, there is a thyroid tissue in the neck, there is thyroid tissue at the entry point, and all that can be avoided if you can bravely dissect the nerve. Because this is not the nerve, this is the thyroid. This is not the nerve, this is the thyroid. This is not the nerve, this is the node. And that way you can do a more accurate surgery and avoid the embarrassment post-operatively when the radionuclide guy will tell you, so much disease was left behind, doctor, what did you do? Now, litigation. It may not happen in our country quite in the near future, but we should be prepared for it. A lot of patients may not voice it today, but when the patient comes, they all come with the apprehension, doctor, mera awaaz to nahi jayega na? Because they have heard somewhere it's happening. That doctor got scot-free. You may not get scot-free. Somebody will say something about you, and you should be very careful the times to come. Cost effectiveness, people talk about this, say, bahut mahenga hai. It's not mahenga hai. And I say this with some kind of a brevity because you're all friends and you'll not misunderstand me when I say this. We don't mind buying a Mercedes. When Maruti car is just good enough, we'll take you from A to B, B to C, C to D. So why do you need Mercedes then? We are spending so much money otherwise, but when it comes to spending some money this side of the coin, oh my God, that's too expensive. So, the tube costs too much, 15,000, 17,000 per tube. I can come to that point later. But this is our own figure of imagination. We will come to it, I will come to that point later. Now, contradictory data on the cost. If you look at the world literature, that doesn't matter to us because there are different statistics over there. But in our scenario, if you use the nerve in the equipment in a sensible way, we can get away because the patients may require phonosurgery. Patient may require loss of work, aspiration. All this can be avoided. I'm not putting cost to it now. I'm putting the inconvenience to it now. The patient should have gone back to work, doesn't go back to work. A patient with this kind of voice cannot function. This all can be avoided, not cost-wise, I'm saying quality of life-wise. Now the mechanism of injury, see, the injury doesn't happen in the neck. I can repeatedly and confidently say, we are all good surgeons, we know what the nerve is, but the nerve gets damaged at the entry point most commonly. And that is also not your fault. I'm not absolving myself from my injuries, but it's actually your assistant fault. I had a little giant who was about 120 kilo, 6 foot tall. In front, I look like a pygmy and people ask me, is he your father? I said, no, I am his father. Anyway, he pulls the patient practically to his side. And the nerve hangs like this. So it is at the entry point where there is a kinking or angulation of the nerve which causes the injury. So how can you detect it? And the people have come up with a fantastic thing called continuous intraoperative nerve monitoring. That means you put a probe on the vagus, and that vagus is continuously being stimulated, and you can keep on getting the signal, it's okay, it's okay, it's okay, carry on, it's still green, it's still green. But if you are tractioning, thermally injuring, the brown light, the red light starts blinking, and therefore you can know, oh, idhar nahi jaane ka, gadbad hai. Now, it is a game changer, but it is again little expensive. There is a lot of criticism on it. I'm just putting the point across to you that this is a possibility to come in future. Oh, thank you very much. It's good, but I'm grateful that they did actually allow me to speak. No, I'll stop anyway. And thank you very much for butting into this session. It is good to stick into the time. So thank you very much, Chairperson. Thank you once more to the Prasad and all his team. Grateful.
Thank you, sir.
Thank you very much, Dr. Kapre.
Now I request chairpersons to felicitate Dr. Madan Kapre, sir.